Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own tumor master, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers access the right treatment at the right time. Hormone receptor positive breast cancer remains the most common subtype of breast cancer, and endocrine therapy has long been the cornerstone of its treatment. However, resistance to existing therapies, often driven by ESR1 and other mutations, continues to be a major challenge in the metastatic setting. Traditional SERD therapy with many molecules has reached certain limitations, particularly because it requires intramuscular administration and may have suboptimal receptor degradation. The development of oral SERDs or SERDs, including molecules like elacestrant, camizestrant, represents an important step forward, offering convenient oral dosing and the potential to overcome endocrine resistance. In today's discussion, we'll explore how these emerging therapies may reshape the treatment landscape of HR-positive breast cancer. It is a privilege to welcome Dr. Krishnamani, a highly respected leader in the field of oncology. For over a decade at AY Hospitals, Hyderabad, he has been at the forefront of cancer care, bringing deep expertise in the management of solid tumors, hematological malignancies, and oncological emergencies. His professional journey includes prestigious international fellowships and key leadership roles across some of India's leading cancer centers, reflecting a truly global outlook combined with strong clinical excellence. Beyond patient care, he has played a major role in advancing oncology practice, contributing to treatment protocols, supporting research initiatives, and helping shape cancer care frameworks. What truly what truly distinguishes him, however, is his compassionate, patient-first philosophy. To his patients and their families, he is not only an exceptional oncologist, but also a reassuring guide through one of life's most challenging journeys. We welcome you for today's session, sir.
Hello and welcome to Cancer Reach. Cancer Reach is an initiative, as you know, to spread awareness on cancer. And today, as you said, we'll talk a little about SERDs, more importantly on where we use SERDs and why we use SERDs and other molecules.
Yes, sir. So, sir, before we get into the oral SERD therapy, can you explain or give us a little bit background about the HR-positive breast cancer?
See, hormone receptor positive breast cancer is a type of breast cancer. So, in breast cancer, 3-4 types. You are hormone positive, or you are hormone negative, or you are HER2 positive. Now you can have a combination of everything. You can be hormone positive and HER2 positive. You can be hormone positive and HER2 negative, or you can be all negative, or you can be hormone negative and HER2 positive. So mix and match everything. So hormone positive, HER2 negative, we will concentrate on this. This is a good variety of breast cancer because you are hormone positive. You can give hormonal therapy or endocrine therapy to stop the growth of the tumor. So if somebody has hormone positive, HER2 negative breast cancer, you can safely say that it's a good disease prognostically, and you have endocrine or hormone therapies. So just view it as a signal which is coming from above, and you're able to block the signal. On the contrary, triple negative, all hormone is estrogen receptor, progesterone receptor. PR negative and HER2 negative. All negative means there is no signal. So I constantly give this example to my patients. You don't have an enemy coming from outside, but you have a problem. That means your enemy is within, in your own house. If I know my enemy is from my neighboring country, which is that is like hormone positive, right? You're having somebody coming from outside. So there I know I have an enemy coming from outside. I'm ready for him with hormonal therapy. That signal. No enemy from outside, no signals from outside, caught unawares. It's a bad disease. The enemy is sitting within the house. So there you can only give chemotherapy. Okay. Now that said, this is a good variety. Hormonal therapy is the treatment of choice. Now in that hormonal therapy, what are the names of the drugs? Tamoxifen is a SERM. We call it selective estrogen receptor modulator. This drug was developed many years back, decades back. Then newer drugs came called aromatase inhibitors, called anastrozole, letrozole. Then we had SERDs, IM SERDs, intramuscular, like fulvestrant. Now newer SERDs have come. Then you also have PIK3 inhibitors. Then you have cyclin-dependent kinase CDK4 inhibitors. So in the hormone therapy HER2 negative space, tamoxifen, anastrozole, letrozole, fulvestrant, elcastrant or imlunestrant, and then CDK4 inhibitors, then certain other drugs like mTOR inhibitors like everolimus, PIK3 inhibitors like alpelisib, exemestane. So you have so many drugs to play around with.
Sir, can you tell us a little bit about the oral SERD? How is the mechanism of action different from that of the existing SERMs or that of the other molecules like the aromatase inhibitors?
So tamoxifen is a molecule which is a SERM, selective estrogen receptor modulator. It acts on the receptor, okay, it prevents the binding of the hormone, but eventually resistance develops. SERD means what it does is it binds to the receptor, it degrades the receptor, it destroys it. So that is why it overcomes the resistance. Patients who are on tamoxifen or who are on anastrozole, they can develop ESR1 mutations. That mutation is responsible for their resistance. So to overcome the resistance, you use this molecule, which is an oral SERD.
Sir,
So it is used in patients with endocrine resistance who have failed one or two lines of treatment.
Sir, so you were explaining about the endocrine resistance and about the ESR1 mutation. Sir, how common is this mutation, or is it not, or is it rarely seen in your clinical practice?
So now we have started doing ESR mutations in most of our patients. Earlier, it was not, what do you say, well appreciated, or the mechanism was not known. Now we do PIK3, AKT, and ESR1 mutations. Based on reports in literature, the reports vary between 5 to 15% or more positivity. Okay. And you will do ESR1 mutations and PIK3 mutations in those patients in whom you are the resistance.
So typically, how long does it take for patients to develop this resistance, or when is this resistance seen that you advise the patients for these tests?
The resistance depends on a number of factors. How strong is your ER/PR positivity? If you're weak ER/PR positive, obviously you're not going to be endocrine sensitive. You will be resistant. Uh, Also, it depends on the how many drugs you are using. Now, if I use anastrozole alone, maybe the patient may progress within 9 to 12 months. You use anastrozole plus a CDK4 inhibitor, you get a longer PFS or a progression-free survival. Uh, the patient may progress between 2 or 3 years. The patient has a large volume of disease. They may be more endocrine resistant. They may probably respond early. They may relapse early. Also, if you had used tamoxifen or anastrozole in the adjuvant setting, somebody had breast cancer, they are put on hormonal therapy after surgery, after chemo. Within 6 months, if they develop disease, that is, you are on endocrine therapy for early stage disease, but within 6 months, you become stage 4. So you have endocrine resistant disease. So endocrine resistance depends on prior adjuvant therapy. If it is a short duration, highly endocrine resistant, what is the positivity of your ER/PR receptor? So all these factors will contribute to your endocrine resistance.
Sir, can you tell us a few of the oral SERDs which are currently available globally or in India?
Elcastrant, immunorestrant are the ones which are available as far as I know. In India, none of them are available, but I think few companies are procuring it for patients, especially Elcastrant, which is an ESR1 uh, mutation antagonist for patients who have progressed on prior AI, that is anastrozole or letrozole, and prior CDK4 inhibitors.
Sir, when we talk about these molecules, how is the data with the molecules? Is it really life changing? Will the patients really benefit from giving been given these therapies?
So right now you have only a PFS benefit. Overall survival benefit is not there, but PFS benefit is there. It is standard of care. In clinical practice, what you should tell your patients is it is likely to work in those patients who have had a good response to prior endocrine therapy. So if somebody has used endocrine therapy and within 3 or 4 months their disease has progressed, then maybe unlikely it would work. So why are you using this? You are using it as an alternate to chemotherapy or to push chemotherapy to further lines because chemotherapy and its toxicity, we are all aware.
Sir, is it correct to understand that these SERDs are being used only in the metastatic setting, or can they also be used into the early breast cancer settings?
Not yet. They are primarily they are used right now in clinical practice only in the metastatic setting after failure of 1 or 2 lines of endocrine therapy.
So, sir, these SERDs, the oral SERDs which are there, are they going to work with ESR1 mutations plus the PIK3, AKT, mTOR? Are they available for all the mutations, or is a specific molecule available for a specific mutation?
Specific. For PIK3, you have a drug called alpelisib, which is used in association with fulvestrant. It is available in the market. We've used it earlier. The problem with alpelisib is it can cause very high sugars. So monitoring, managing the sugars becomes a problem with alpelisib. Uh, ESR1 elcalistrant is only for ESR1 mutations, not for PIK3. But the testing is done on the tumor where you test for PIK3, ESR1, and AKT, and now the cost of the testing is between 7,000 to 10,000.
Sir, are there any specific monitoring parameters when a patient is put up on these drugs? Like you have already said for alpelisib, what about the other molecules?
Fatigue is a common side effect, nausea. We ought to check them for their liver enzyme functions. These are some of the things which we have to say. When we put them on drugs like the CDK4 inhibitors, we check their electrolytes, we check their ECG, the urine protein. So I prefer to do the same for patients on this also. But more importantly, you're looking at liver function abnormalities, some nausea, fatigue, and weakness.
Sir, do you think the oral SERDs will only go in combination with other molecules, or they will be used as a monotherapy also in a future purview?
So if you have used, see, in right now it is going to be used as a monotherapy. We have to see how the toxicity is what we have to measure. So the risk benefit ratio, we say, when you go from one line to another in the metastatic setting, if you use combination therapies, your side effects are going to be more, your quality of life is going to be poor. So most likely they are going to be used single-handedly only. If results show that in combination they're doing a much better job, then probably you will use it earlier.
Sir, looking ahead, like in the next 5 years or maybe in the next 10 years, do you think the oral SERDs will transform the endocrine therapy landscape in HR positive breast cancer?
It's already doing. The IM SERD is your fulvestrant, which has been there for so many years now, and fulvestrant is your drug of choice in second line after AI, anastrozole and letrozole. So this is just a variation of that. You're also looking at SERDs which cross the blood-brain barrier, like immunoclastrant. So newer molecules are going to come more efficacy, less toxicity, okay, and to the Indian patient at a better price point. So it will be helpful. And what do you say? You're trying to avoid toxic chemotherapy.
So, do you think chemotherapy will become a null and void kind of an option moving forward in this breast cancer setting?
It already is, right? So many patients, we have so many patients who progress on tamoxifen and then we put them on anastrozole and palbociclib. We didn't have palbociclib 7 8 years back. Now you have palbo, ribo, abemaciclib, and if you progress on that, you go on fulvestrant. You progress on that, you go on alpelisib, then you have elcastrant, you have everolimus. So offhand, many clinicians would probably remember patients 5 years, 7 years down the lane. They are still on oral medications or hormonal therapy without the need to go for chemotherapy. So I can remember a lady, so 5.5 years she's been on fulvestrant. Almost every month she comes, she takes her fulvestrant shot and she goes. Now she makes it every 28, every 2 months she comes and takes the shot. Her scans every year are almost in remission. So there are many such patients. And there are few such patients, I should say. There are many such patients who will have ups and downs in their course, but you use different kinds of these agents and you can take them forward.
So can you summarize today's session for our audience?
The bottom line I want people to know is hormone positive, HER2 negative breast cancer is a good variety. Even in stage 4, the survivals are excellent. You don't need chemotherapy unless you are in visceral crisis. Visceral crisis means your lung and liver is so badly damaged that you need chemo to immediately reduce the disease burden. Otherwise, anastrozole, letrozole, cycling CDK4 inhibitors like palbo, abema, ribociclibs, tamoxifens, fulvestrants, oral SERDs like elcastrant, all these are wonderful drugs. Test for ESR1 mutations. If you are progressing on hormonal therapy, if you are ESR positive, go for elcastrant. It's not yet available in India, but people are procuring it. It will become very cheaper very soon. And we are slowly and steadily moving away from, we've already moved on, we are moving further away from chemotherapy in this good variety of breast cancer where patients do live long, even in stage 4, and with a good quality of life.
So can you tell us a little bit about the second opinion campaign which is being run by you?
We have a second opinion campaign on Cancer Reach. Patient, we have a number on WhatsApp. You can put your reports. We have a Google form. Upload your forms, reports, and we'll get back to you. It's free. And the reason is to guide people who are in remote areas where there's no oncology expertise available. And you can take obviously treatment at the place where you want, but at least our way of helping out.
Thank you for enlightening us on this topic for today, sir. We hope to meet you again next Friday with another interesting topic. Thank you for your time, sir.
Thank you so much. Bye.